I'm Matron Tan from Hospital Pinang Cardiology Department. Today, my task is to help you all to recognize ECG rhythm. First of all, we need to know what is ECG rhythm. You need to know about the graph. Okay, from the horizontal graph, you need to see how many seconds is it. One small square equivalent to 0.04 seconds. Therefore, if 5 small square equivalents to 0.2 second. How about the voltage? The voltage is from the side here, the vertical side is 1 small square equivalents to 0.1 MV. If you have 10 small square, so it will become 1 MV. So this is important because we need to know how many seconds in order to know whether there is any abnormality or not. Because in the PR interval, it might be more than 5 small square. Or in the QRS, you need to know the rod of the QRS, it would be not more than 0.12 second, means cannot be more than 3 small square. Once it's more than 3 small square, it becomes slower. Okay. P wave represent your atrial depolarization. QRS represent your ventricular depolarization. Okay. How about the T wave? T wave is the repolarization of your electrical activity. Okay. So normal P wave will be upright and normal QRS complex will be narrow. Means it will be less than 0.12 second. Okay. How about the T wave? It should be upright. Unless if you have the U wave, sometimes you might have small U wave after the T wave because it represents the hypokalemia. Okay. ST segment is also important. ST elevation represents infarction. If ST depression represents ischemia. I would like to teach you how to count the heart rate. We have few methods. Okay. First method is just roughly when you look at that rhythm, you can know whether it's tachy or brady. It depends on the RR interval. If the RR interval is between 3 big square, then it is very, very tachy. If the RR interval is more than 5 big square, it shows bradycardia. Next, the second method is you can count the small tiny square between the RR. Okay, the formula is you use a 1500 divide by how many small square between the RR. The sample that I show you is already counted out is 23 mm. Okay, so therefore the heart rate will be 1500 divided by 23. So it's 65 beats per minute. This is the most accurate method. Okay. Yang third one, you can use the 300 divided by how many bits square in between these two RR interval. Okay, let's say R to R, if you have 2 big square, so it becomes 150 bits per minute because you are using the 300 divided by 2. So equivalents to 150 bits per minute. If you have 5 big square in between your RR, so 300 divided by 5 equivalents to 60. So still in between the sinus rhythm. Okay, the fourth method is you use a 6-second strip. Later I will show you how to count the 6-second strip. Okay, from there you count in between this 6-second strip how many R wave is there. Here I'll show you the 7 RR is between the 6 seconds. So you just times 10 equivalents to 70 beats per minute. This method is good for the irregular heartbeat. For example, atrial fibrillation. So you can just count how many R in between these 6 seconds times 10, then equivalent to your heart rate. Okay, this is the example how to count the 6-second strip here. You can look at on top here, there's a marker. You have 3 markers here. So between here to here, first marking to the second marking is 3 seconds. And the second marking to the third marking is another 3 seconds. So total is 6 seconds. Usually all our ECG rhythm will have this. So you just count from the marking from here. Okay. So how many R wave is there? Just times 10 equivalents to how many beats per minute. Next, I'd like to show you all roughly a little bit about ST elevation. Okay. So can see from here, from the graph, ST elevations means what? It's infarct pattern. This ST elevation is very important for you to recognize the infarct pattern, because in our ECG rhythm, we will give you this pattern. But for recognizing the ECG rhythm, you no need to worry about the ST elevation or ST depression. Okay? So next, also, for example, another example of the ST elevation. Okay. How about the ST depression, whereby it shows the ischemia of your heart? Can you look at the ST segment there? Okay. Below, it depressed at 1.6 mm. So this one shows that ischemia pattern. Okay. In order to let you know, because once you cannot recognize the ST elevation or ST depression, sometimes it's difficult for you all to recognize the rhythm. So you feel very hard. Hey, what is this rhythm? That's why I let you all know something about the ST up and ST down. Okay, another example of the ST depression. Okay, now we come to ECG analysis. There's few questions, very easy questions only. Okay, first, when you look at the ECG, one rhythm strip, first thing you must look at is whether is it tachy or brady. Remember just now I told you all, if the RR interval more than 5 big square, yeah, that is brady. Then how about if the RR interval is less than 3 big square? Yes, is tachycardia. So roughly, from one glance, you should know whether it is tachy or brady. Okay, next, you must look at the rhythm, whether it's regular or irregular. Okay, because from here you can recognize whether there's some PAC, PVC, or whether it's an atrial fibrillation. Okay. After this, the third one is you must look at the QRS, whether it's normal or not. Normal QRS complex should be less than 3 small square. So, it should be less than 0.12 second. So, everything below 0.12 second, the pacemaker comes from above your ventricle. So, either it should come from your SA node, AV node, above your AV node. Okay, when you become lower, then it becomes broader. So, remember to look at the normal QRS complex. Okay, after this, then you go back to look at the P wave. P wave represents your atrial depolarization. So, you want to know whether it comes from the SA node or not. So, if it comes from your SA node, you should have one upright P wave. Okay? Last, we should look at the relationship between the P and the QRS. So we want to know whether the husband and wife, their relationship is good or not. If no good, there's some abnormality. Okay, right. So now I'll show you the first graph. Okay, what does it show? I already given you the rate 83 using the 1500 divided by how many small square between the RR interval. So, right here, we will give you the rate of 83. Okay. So, now we look at the QRS. Is the QRS narrow or broad? Of course, it's narrow because it's less than 0.12 second. So, how about the P wave? P wave is upright. So, it shows that the pacemaker comes from your SA node. Okay, the PR interval? Normal. Okay, abnormal PR interval will be more than 5 small square. That means it will be more than 5 times 0.04, 0.2 second. So, if the PR interval is between 5 small square, it shows that the interval is normal. That means it still come from your SA node, go to your AV node. Okay? So, relationship you already know, P, Q, R, S, T, already you know. Okay, so this rhythm shows you sinus rhythm, correct? How about this? So, first, is it tachy or brady? Of course, it's brady, right? Between the RR is more than 5 big square. How about the QRS? Normal, still narrow, P wave upright. The PR interval also is between the 5 small square. So therefore, this show you a sinus bradycardia. So far, okay? Okay, next, I will show you something is more tachy. Okay. So, rate 1005 divided by 12. Small square between the RR equivalent to 125. 125 beats per minute. So, of course, it's tachycardia. Narrow QRS, upright P wave, normal PR interval. So, this one will show you sinus tachycardia. So, very easy. Whichever pacemaker coming from your SA node, it will give you the rate of between 60 to 100. In this kind of pattern, the rate is less than 60, this is sinus bradycardia. And if the rate is more than 100 to 150, this is sinus tachycardia. So far, okay? Okay, next I'll give you a little bit of challenge. Okay. What is this? Is it normal? Of course, it's not normal, right? You can see something up there, jumping out there. Can you find a P wave? Can you find a T wave? Cannot, right? There's something funny pattern here. Okay, this is what we call flutter wave. Flutter wave, actually the pacemaker come from one part only. Okay, so when this pacemaker, it will start, and then when it start fire, it will go down to your AV node. But in order, if your AV node allow the rate of 300 beats per minute to go through to your ventricle, what you think about patient? Can the patient survive at the rate of 300? Then patient might have VT. Patient might die, okay? So, the good of our AV node is so fantastic, okay? It acts like a traffic controller. So, when your atrium fire at the 300, so once you go down to your AV node will say, no, I won't allow you to go. So, the pacemaker will go back to the same, correct? To the same pacemaker from your atrium. So, you have one flutter wave. Okay, after that, it will still fire. Still cannot allow it to go. So, you have the second wave. So, maybe you can have the third wave when the AV node not allow it to go. Okay, come at the time that AV node say, okay, already a bit slow down, I'll let you go. So once it let you go, then you will go through your AV to your left bundle and right bundle. Then you have your QRS there. That's why you have so many flutter wave here. It depends on how many times the AV node allow it to go. Okay? Atrial flutter have the flutter wave, something like the sawtooth. Okay, next. Can you see the rhythm? It is very irregular. Can you see any regular rhythm there? No. So, usually this kind of irregular pattern, you will call this as atrial fibrillation. Atrial fibrillation, it comes from your atrium also, but it doesn't come from one pacemaker. It comes from different pacemaker from the atrium. That's why you can't see any nice P wave there. You can only see the fibrillating wave over there. Okay? And this is the good example when you look at atrial fibrillation, how to count the rate. You can use the 6-second strip. See how many RR wave is there times 10. So that is the atrial fibrillation. The rate, how you count the rate. Okay, I have few more sample for you to see. This is also the atrial fibrillation pattern. Okay, next. Remember just now we say when the pacemaker come from your SA node, So when you have sinus tachy, the rate is between 100 to 150. There you will have one upright P wave because it comes from your SA node. Okay, so how about this? How come the rate is so fast, 187? Can you say this is sinus rhythm when the rate is at 187? Of course it's no. Okay, can you see the upright small tiny P wave there that I show you over here? So you can't see a nice P wave there because the heart is beating so fast. Of course you cannot see a nice P wave. Okay, so you can see the tiny upright P wave over there at the rate of 187, whereby your QRS is narrow, very, very narrow. So this shows you the pacemaker come from your atrium, nearby your SA node there. Okay. So this is what we call atrial tachy. So once again, just to remind you all, sinus tachy, the rate is from 100 to 150. Those rate that narrow complex with rate more than 150 above, usually you will recognize it as an atrial tachy when you can see a small tiny upright P wave in front of your QRS. Okay, now we come to junctional rhythm. It means that your SA node is filled, cannot fire anymore. Atrium also unable to fire. Therefore, your AV node took over the function. But when your AV node took over, the rate will be more slower. Remember, sinus rhythm give you around 60 to 100. AV node only can give you 40 to 60 beat per minute. Okay, if the rate is between 60 to 100. This is what we call accelerated junctional rhythm. Normal junctional rhythm is 40 to 60. If you see the rhythm is between 60 to 100, this is what we call accelerated junctional rhythm. How about if the beat is more than 100 beats per minute? So it's called junctional tachy. How to recognize this pattern? So we have few characteristics for you to learn. Okay, first, can you see what happened in front of your QRS? There is an inverted P in front of your QRS. Okay, why? Why it happened? Okay, remember AV node also include the bundle of His. Okay, so if between here, let's say the pacemaker started from the proximal part of your AV junction as shown in the graph. So the pacemaker will start to fire and it will retrograde, depolarize the atrium. Therefore, you have the inverted P before the QRS complex. Clear? Okay, as shown in the graph, see the graph? The star there shows the pacemaker started from the proximal part of your AV node. And it will retrograde, depolarize the atrium. That's why you have the inverted P wave before the QRS. Next, what happened here? Can you see an inverted P after the QRS? Yes. Why it happened? Because, see the star there? The pacemaker started from the distal part of your AV junction. So when it starts from the distal part of the AV junction, it will depolarize the ventricle first. So you have the narrow QRS complex. After that, it will retrograde, depolarize the atrium. So you will have an inverted P after the QRS. The third one is there's no P wave before the QRS or after the QRS. Why? Okay, now see the star? Where is the star from? It's in the middle of your AV node. So the pacemaker fire from the middle of your AV node. Therefore, it will depolarize atrium and also ventricle together. When it both depolarize together, your atrium is a small mass and your ventricle is big. So can you see your P wave? Of course, you can't see. It's just like a ikan besar makan ikan kecil. So you can't see the ikan kecil, right? So same thing. So you can't see any P wave in front of your QRS. So this is what we call characteristic of the junctional rhythm. 3 pattern, okay? One is inverted P before your QRS. Second one is inverted P after your QRS. And the third one is no P at all in front or after your QRS. Okay, this is 3 characteristic of the junctional. Okay, now let us look at this rhythm. What is this rhythm? Accelerated junctional rhythm, right? Okay, next, let us look at this. Junctional tachycardia, right? Next, can you see the P wave in front of the QRS? Of course, yes, it's inverted, but the rate is only at 50 beats per minute. So, therefore, we call this is junctional rhythm. Next, after the junctional, we like to show yours from the SA note to your AV note, there's some delay. Okay, so usually normal PR interval is around 0.2 seconds. It cannot be more than 5 small square. Can you look at the graph? Is it more than 5 small square? Yes. QRS is narrow, P wave is upright, but the PR is prolonged. So we call this is a first degree AV block. So there's some delay in your AV node. Okay. So for first degree AV block, the only things you need to know is prolongation of the PR interval. How about this? There is some pattern. Can you see the QRS? This is narrow. Okay. P wave all upright. Okay. Can you see there is a misbeat over here? Can see the P wave without the QRS. Okay. And then some pattern over here. Look at the PR interval. The PR interval is progressively prolongation. So from here, you see, from here slowly it progress and here come a misbeat here. Misbeat means you can see the P wave, but you can't see the QRS. And it comes again. Prolonged PR interval followed by a drop beat again. So this is what we call second degree AV block Morbitz type 1. Another name is Wenckebach. Wenckebach or second degree AV block Morbitz type 1. So the characteristic of this is progressively prolongation of the PR interval followed by a drop beat. How about this? Another pattern. Okay. Can you see the PR interval? It's constant. So there is a different. Can you see any misbeat over here? So many, right? So many beat speed over here. Misbeat. Okay. So, but the PR interval is constant when you count at the graph here. Okay. So when the PR interval is constant and you have the misbeat, this is what we call second degree AV block Morbitz type 2. So the difference from the type 1 and type 2 is PR dia akan constant in Morbitz type 2. In Morbitz type 1, the PR will be progressively prolonged. So next, look at this. Can you see misbeat here? Yes, you have 1, 2 misbeat over here. And the PR interval is constant. So what is this? Of course, is second degree AV block Morbitz type 2. Here come with the complete heart block. Complete heart block, that means there is a AV dissociation already. Your atrium will fire at its own beat and your ventricle also will fire at its own beat. Okay, so there is no relationship between your atrium and your ventricle. PP constant, RR also constant, but the PR is not constant. That is the characteristic of your complete heart block. Now we will come to the ventricle. Okay, ventricular rate. Any pacemaker comes from your ventricle, it has to be broad QRS because it takes longer period to depolarize your whole ventricle. And the rate is 20 to 40, we will call it as idioventricular rhythm. If the rate is between 40 to 100 beats, it is accelerated idioventricular rhythm. And when it's more than 100, of course, we call it as ventricular tachycardia. Okay, let us show you the first graph. Is the QRS narrow or broad? Yes, very broad. Because your SA node fail, your AV node also fail. In order to help us to survive, your ventricle took over as a pacemaker. So your QRS have to be broad and the rate have to be very slow. So right now it's only 35 beats per minute. So this is what we call idioventricular rhythm. Another name is slow VT. Okay, very slow. It's a VT pattern of VT, but the rate is very slow. How about this? The QRS is also broad, but the rate is higher, a little bit faster. So we call it between the 40 to 100. So we call it as accelerated idioventricular rhythm. Okay, next, if it fires so fast, more than 100 beats per minute, and the QRS is so broad at the regular pace, so this is ventricular tachycardia, monomorphic ventricular tachycardia. Okay, next, how about this? Can you see any organized rhythm over here? None, right? Yeah, this is what we call ventricular fibrillation. Your heart is feel to depolarize constantly. So it's just fibrillating over here. Just like your atrial fibrillation, that your atria is fibrillating. Now, your ventricular is fibrillating only. So can it pump? Of course, no. You're unable to pump, right? So patient need to resuscitate, need to do what? Defib immediately. Next, this is what we show you fine VF. This is what we call fine VF. We can have coarse VF, we can have fine VF. If you are acting so slow, of course, from coarse VF, you will slowly go to fine VF if you took 10 minutes to defib the patient. Therefore, defibrillation have to be fast and it will revert quite fast if you can act fast. Okay, next, what is this rhythm? Of course, everybody know. Asystole. How about this? This is what we call RNT phenomenon. This pattern, when there is a premature ventricular beat falling on the previous T wave, so it might cause RNT phenomena. This is very important because it might cause VF. Natural history of VF. Just like just now I told you all, if you act too slow, what will happen? See? Okay, cause VF. Slowly, 2 minutes, it become more fine, until asystole. So everybody remember to act fast in order to save the patient's life. Okay, next. Can you see there's some funny pattern over here? This is what we call tosa de pois. It's a one kind of polymorphic VT. The difference from the VF is here you have one pattern. Where there is a twisting point, I will show you few pattern of tosa de pois. This. Okay, how about your heart when it's dying? What will happen? Can you see the just 2 beats over here with very broad complex? This is what we call agonal rhythm. The heart is dying. Okay, this is the rhythm that we don't like when we resuscitate the patient because patient is going to die. And yet, still having few beats over there, you can't sign the death certificate. Okay, finish everything already. Now we are going to teach you about what is PVC. Premature ventricular beats. Okay, can you see the rhythm is so broad? And these 2 beats is exactly the same. Rhythm is at PQRST, the rate is at 88. It's a normal sinus rhythm, but you have two identical PVC. Here we call it as unifocal PVC because these two PVC is exactly the same pattern, right? Okay, how about if these two PVC come together, two together? So this one we call it as couplet. Just like you want to go Patong, so you need two person, right? So couplet, couplet. But because of the same morphology, the pattern is the same, therefore we call it as unifocal PVC couplets. Okay, next, how about if three together? Triplet. Tiga anak keluar, triplet lah, nah? Or another name is salvos. So if your PVC is more than 5, we call it as short runs of VT or non-sustained VT. If sustained VT, it will show like this. Yes, this is we call ventricular tachycardia sustained VT here. Okay, this one also you need to act fast. VT. If patient is stable, then you can give some medication. If patient is not stable, then you need to cardiovert the patient immediately. Another example of your VT. Okay, here come another pattern. Remember just now I show you all is unifocal PVC. It comes satu biji like this, followed by your normal rhythm, or it comes two together where we call couplet, three we call triplet. The pattern here is different. You have one sinus beat followed by one PVC. One sinus beat, one PVC. One sinus beat and one PVC. This is what we call bigeminy. Unifocal PVC, another name is ventricular bigeminy. Means you have one sinus, one PVC, one sinus, one PVC. Okay, how about this? If you have two sinuses, two sinus beat followed by one PVC, two sinus beat followed by one PVC, this is what we call trigeminy. In between the three, you have two sinus beat and one PVC, so you call it as trigeminy. PVC, okay? How about this? Can you see the broad QRS between here? Is it identical like just now? No, it's different configuration. Okay, one up and one show down. This is what we call multifocal PVC. But at the same time, can you see over here, you have three sinus beat followed by one PVC. Three sinus beat followed by one PVC. So this is what we call quadrigeminy. Either multifocal PVC, but the pattern is quadrigem. Next, this is what we just now I told you already. Different configuration of the PVC is multifocal PVC. Okay, can you see any irregularity over here? The first, second, and the third is the sinus beat. Okay. Come to the fourth one. There is one upright P in front of the narrow QRS. But the configuration of the P wave is different from the normal sinus beat. And it comes early than you expected. Okay. So, this is what we call PAC. PAC is a premature atrial complex. Or another name is supraventricular complex. Everything above your ventricular is all supraventricular. Next. Okay. Can you see or not? 1, 2, 3, 4, 5. All the first 5 beats is normal sinus beat. And come here, there is something come early than expected. But you can't see any P wave in front, right? Remember just now I showed you all when there is no P wave in front of the QRS, it belongs to the junctional site. Therefore, we call this one as a premature junctional complex. How about this? Can you see any 1, 2, 3? The first 3 beats is sinus beat. The fourth one, come early than expected. No P wave in front. So, it's PJC. Okay. Can you see there is a spike in front of the QRS? Normal beat, we don't have this spike. Okay, this is what we call ventricular pace rhythm. When it pace at the ventricle. So if patient incomplete heart block, we need to pace it. So usually they put in a temporary pacer, then in the rhythm will show you this thing. Okay, how about this? If you see one spike before the P wave, this one also a pacemaker beat. Okay, it's an atrial pace rhythm because you can see one spike before the P wave. So it shows that the leads is going to your atrium. Next, how about this? You can see one spike before your QRS and also one spike before your P wave. So this is AV sequential pace rhythm. Dual chamber. That means there's two leads. One go to the atrium, one go to the ventricle. Okay. Okay. So another pattern of dual chamber. One spike before the P wave, one spike before the QRS. Okay. Something wrong here. You can see a spike, but you don't see any QRS. So this is what we call non-captured pace rhythm. The pacemaker is firing, but it doesn't capture. So there's something wrong with the pacemaker. We need to adjust the leads. Okay, next. Okay, artifact. Few types of artifact for you all to learn. This is due to AC line interference. Next, this is due to the muscle tremors. And this is due to the loose leads. Last is due to the artifact due to the biotelemetry. Some of the patients need to monitor the telemetry. So when they move around, so you might have this artifact over there. I think that's all for today. So hope you all can learn from here. Thank you.